NGS has been used for clinical testing probably over a decade. However, the routine usage of fusion detection by NGS is not that often. So this is quick disclosure, and Thermo Fisher pay my registration fee here, flight ticket, and hotel. It's my quick disclosure. My talk will mainly in two parts. First, I will talk about how to quantitate NGS-based fusion detection. Second is mainly to my experience in the 1 year, how to use this quantification of the fusion detection. NGS, especially fusion detection, mainly for the solid tumor, has been widely used. But comparing solid tumor, the percentage of neoplasm with fusion is much higher in myeloid, about 30%, not mentioned the lymphoids. As it first discovered, the first approach is by cytogenetics and fusion. As you can see here, we have two probes with different color. When they fuse together, form a fused color. With the development of PCR, especially RT-qPCR and qPCR, these are all also developed as the fusion detection. However, as we looked at the previous page, a molecular lab, it's hard to really keep a large collection of different probes for the different RT-qPCR. So now it's the time for NGS. And why NGS? Well, I would say, why not NGS? I always want to say that NGS is a one-stop shop. For myeloid neoplasm, we can detect SNV like JAK2 in their NPM1-3, and fusion translocation of BCR-ABL in one tube or one test. And save sample. And as a hematopathologist, you guys, you don't need to send a sample to different labs. And otherwise, if the platform is as efficient as we are using, the turnaround time will be much shorter. What really excited me as a molecular pathologist, because I hate to be recognized as an IHC lab, is what we can bring on the table more than detection is quantitate NGS result, how that part can help clinical practice. So this is where the focus for me is really how to use NGS, especially with fusion, for disease surveillance and also ultimately for the MRD. RNA-seq is a little bit different from DNA-seq. You might know that DNA-seq always you get a report, you will see a VAF there, or very allele frequency. But this doesn't happen for RNA-seq because the messenger RNA level varies in different cells. That's why you don't expect VAF. What do you got? So that's why we cannot use tumor percentage for the validation. And so that is the first part of my focus. So this is the assay we launched April 2024. It's a 45 genes, including FLT3, ITD, and also fusion. 35 genes, but it's a multiplex-based fusion detection, over 700 different fusions. Turnaround time 1 to 2 days. So first question, how to define the limit of detection? So before we jump to the concept, one thing I want to emphasize that DNA-seq reads is the examination of the tumor content, and RNA-seq reads really the copy of the oncogenic fusions, BCR-ABL or PM-RARA, like that. So what we did first is use the synthetic RNA and do a linear dilution. And as you can see, most of these 6 different type of fusion has very good correlation, and we get a sort of cutoff reads here. Still, to better have an idea of limit detection is to have a clinical sample. There's no better clinical sample than P210 in our clinical lab because we use it routinely for our CML or BAL patient surveillance. So on the left, you will see a correlation between the reads versus the IS international level of the P210. So we get a very good correlation here. And on the left, on the right side, is the LOD, as you can see here. As long as the reads over 70, we can get 100% sensitivity to detect BCR-ABL. However, if the reads is lower than 60, this part we cannot detect. Understandable because there's a limitation of the NGS. But most important is the specificity. We didn't get any false positive. Each negative result is negative by the qPCR. I know this already sounds very boring, too many real data here. Let's jump to patient samples. So this is a patient, 59 years old. ETV-able1 fusion is not unusual. And patient CML patient. Patient was on imatinib first, but as you can see, by October 2025, the white count really jumped. And also the cytogenetics is positive. The reads is extremely high. It's over 28,000. So the clinician switched from imatinib to dasatinib. And 2 months later or 3 months later, the white count close to normal, and cytogenetics was not performant. Accordingly, you can see the NGS fusion reads reduced about threefold, 2 times actually. And a few weeks ago, we tested this patient again, and the clinician was very excited. He wants to write a case report with me because for him, that's really the treatment works. The dasatinib for the ETV6-able1, this is very rare. But for me, very excited that we still can detect very low fusion reads, even the cytogenetics is positive. So which means that at least from the change of the reads, I hope you can agree that the NGS reads can use to monitor molecular response. So this is the first part. Second part, probably more exciting, is to show you in the 1 year practice. We launched April 2024, and this is data about a year ago. We sequenced both DNA and RNA for 658 samples and got a 500 positive. Among these, 81 patient samples show positive for fusions. These are the 60 patients. And the majority is AML, 47, and 20 is CML, and 12 BAL, and 2 MDS. And the next, I will show you each different type of fusion as a comparison with FISH results and the cytogenetics and other cytogenetics. First, there is 100% concordance between the BCR-able results between the NGS and the qPCR, majority is qPCR, or cytogenetics FISH. In this patient, the reads is pretty low, and both cytogenetics and the karyotype are normal. Flows show less than 1%, and the HLA show over 95%. We can detect it, and this is consistent with qPCR. Sorry for typo, it's qPCR. So this is BCR-able. Next is, well, might be more interesting to you as a hematopathologist, Pierre-Marara. In 1 year, we had 5 patients with APL with 11 samples. And among them, 2 samples actually turned to be normal from the FISH. Our FISH is breakpoint FISH. So I'm going to show you one case here. This is patient, 51 years old, female. She actually came to our town for a wedding, and suddenly she feels uncomfortable with it. Very, very sick, as you can see, the white count, hemoglobin, and especially the coagulation, the plate count point out this patient has DIC, so potential APL, and she was put on Archer right away. So this might be interesting for the hematopathologist. As very commonly seen, it's c-KIT positive, MPO positive, and also CD30 positive. But it's a little bit unusual because the CD34 is also positive, but morphology-wise, it's microcytic type. So it's still fitting the rare type of the APL until the FISH is normal. So this is a breakpoint FISH, and for Marara gene, and if it's positive, you're supposed to see the 2 green dot and the red dot will be separate, but here it's fused together. We did NGS simultaneously. We detect a fusion of Pierre-Marara. P3R3 means like this is exon 3 of PML gene. It's a short form. Just give you a little bit background. There are 3 three forms of the Pierre Morara in terms of messenger RNA level. Could be short form and long form. Short form versus the exon 3, the long form exon 6 and 7. The reason why such cryptic fusion possible exists because the probe sometimes is not large enough. Even the probe here, even this probe is very large. I mean, very long. It's for 15 kb, but sometimes breaking point could be a DNA level can out of this range. That's why the fusion detection, the FISH detection fails. And so in summary, for Pierre Morara, 11 samples and 5 patients. Concordance are 6 patients actually, and 2 patients turned to be FISH negative. The even worse part is the second patient actually, they stopped Archer because FISH was negative, and until our NGS turned 9, and then they restarted Archer. Not all cryptic type is caused by the short form, because our second case actually is the P6R3. So this is Pierre Morara. This is CBFB MYH11 fusion. There are 14 cases. 11 cases was normal by positive by FISH. 3 cases were normal, but these 3 cases are NGS positive. As you can see, the reads are pretty low. Just point out that really at the low level, NGS can detect it. Move on to KMT2A. Similarly, very low reads here. All normal, even by flow cytometry is normal, or less than 1%, and the NGS can still detect it. NGS is not always the winner, and we have 2 cases. Beyond this, 81 cases actually was 2 cases was normal by NGS, but positive by FISH. This is because I don't want to expand really the technology of RNA-seq. The method we are using is this one. Is based on the multiplex PCR method. The left one is the 5' race. The right side is the hybrid capture. So the middle method, which we are using, is limited by a non-fusion partner. So if there's no novel fusion partner, this might be missing. That's why we missed 2 of them. This is some rare fusion. Again, as you can see, that's as long as the reads is high, it's always consistent. And if the reads are low, extremely low, then the karyotype of FISH will be negative, and the flow is also negative. So in summary, among 81 cases, the majority of cases consistent between FISH or qPCR and NGS. However, 11 cases here with low reads, they only detect by NGS. And also there are 3 cases because the cryptic fusion and FISH failed to detect it. Well, you might argue at this moment again, say, how do I know these low reads are real positive? It's just because all these cases has been positive before. Let me show you one case. So this is 62 years old with AML in version 16, relapsed September 2024, then chemo 1 month later. So we have 3 time points here. And the first is when the relapse happened. And as you can see here, the FISH is 69% positive and 38 breast positive. And after chemo a while ago, and FISH was totally undetectable and normal, and breast is 0.4%. It's neglectable. That's another reason to test 1 year later. We not only detect for all these tests, we also send out for the qPCR. And it came back with the very low tumor burden, the 3 of the 10,000. So how's the reads? The reads was very high at the beginning, before the treatment, and reduced significantly a few months later, And until now, consistent with the qPCR from the blood, and we still can detect 280 reads. So this is really the confidence we can call it. Well, what is the clinical significance with this low reads? Could this really mean the early relapse? How this will help clinical practice? I hope I can conclude with this in the last case. So this is a patient with ROS1 confusion, did allo back to June 2024. And we have 4 tests here, 2024 October and December, the early of 2025. Unfortunately, the patient passed away in June 2025. So really relapse and collapse very quickly. If you pay more attention to the different test results here, first, I bet a lot of hematopathologists here, as you can see, his fish is normal at first beginning of October. And then flow cytometry is also 1% blasts, and HLA shows 100% donor. 2 months later, still fish is normal, 0.7% blast, and still HLA is 100% donor. Another 2 months later, fish is still normal, and the flow is normal, and donors show a little bit, 5% of the recipients. Then 2 months before patient passed away, the fish was, because of insufficient material, and flow showed 4.2% blasts and 25% donor. So this is really, that time the clinician really start to feel different. However, if you look at the reads change, at the very beginning, we already can detect 270 reads. And 2 months later, it increased 10%. Another 2 months later, 5%. I mean, not 5-fold, 10-fold change. 5-fold change. And 2 months before the patient passed away, it's already the 7-fold change in 2 months. So it's really exponential. So I hope I can convince that this is an example which we can use. NGS as a molecular relapse can detect 6 months earlier than other method. So thanks for your time. What I really developed first part, deliver first part is a little bit boring. I just want to show you that how we can use a in-house P210 to really quantitate NGS, especially messenger RNA-based RNA fusion. And the more exciting, the second part is really how we can use this help clinical care, especially for oncologists, how we can detect the disease earlier than other conventional method. So I show you 2 methods, 2 cases here, both as comparison to the fish. Especially the last case, we can detect the disease 6 months earlier before conventional method detected. And this work was done at UCSD.